Hello real clinicians. In a previous video that I prepared with Dr. Koch about case selection for the general dentist, a good question came up by one of our viewers. And
hi, Annie here. I heard Dr. Koch, so how can I help you, Dr. Nasseh?
all right, Annie, so let me tell you about this question that came up by one of our viewers. I thought it was a very good question. I thought it merited making a whole other video to address this question. And the question was, if you have a busy day at the office and you have a patient that comes in with irreversible pulpitis and the tooth that has the problem is very difficult to access, it's above and beyond what you're comfortable with doing as a restorative dentist to access or even do a pulpotomy, then you obviously call your endodontist, and your endodontist is too busy, can't see the patient for several days. Right? So how do we deal with that? What should the general dentist do at that point?
Okay, let me just reverse back a little bit here and go over some of these things. I think the first thing that Ali addressed, which is absolutely dead on, is that if you as a provider, if you don't feel comfortable opening up a tooth, obviously if it's an acute pulpitis, you can get some palliative treatment by doing a pulpotomy. But if for whatever reason that the patient is a difficult management case, that it's got a crown on it, whatever, if you don't feel comfortable doing it, don't start it. That's the one thing we can totally agree on. The second thing I think, Ali, is I think everyone needs to have kind of a pecking order of their specialists, their referrals. So if the number one, A1 endodontist can't see that patient that day, you've got another person that you can go to. I think the other thing here that obviously all of us as healthcare providers, we're concerned about our patient's welfare. You want to make this patient comfortable if it's going to be to the end of the day before they can see endodontist B or C. And I think one of the things that we could do in this instance, and maybe you've done this too, is give them a block.
Yeah, of course, that's one way to do that. But I think let's go back here again to the beginning here of dealing with the relationship between the endodontist and the general dentist. It's very important for you to have a very good relationship with your endodontist, so that in cases like this, they can come and help you, so that they can see your patient on the same day, and even at the end of the day.
And let me take a couple of things about that. Endodontist is kind of a joke. Endodontists provide a great service. It's a good profession, but you don't eat lunch, because I think routinely, especially when you're building your practice, you're seeing emergencies during lunch. Here's another thing for that relationship thing between an endodontist and a general practitioner. Don't just send your endodontist cases where you broke an instrument. Don't send them cases where it's been a problem. That's how you start to build a relationship with the endodontist. They're not expecting you to send them anteriors and premolars, but they do molars like general practitioners do anterior teeth. But what it does for you as the general practitioner, Al, it helps you establish that relationship. So when you have this like, oh my God, help me, they're going to step up and they will fit that patient in. And I think oral surgeons historically have also been very good at that. Send them over, I'll get to them when I can get to them.
Yeah, that's absolutely true. And I think that's for the endodontists or endodontic residents that are watching this, they also have to understand that, there's a need for the restorative dentists and general dentists to have their patients taken care of. And the ability to see emergency patients on a timely basis is really a critical component of the success of an endodontic practice.
That's what it means being a professional.
Right.
And then let's go back also to the thing about the anesthesia, because if you're trying to buy some time, you can reduce the occlusion. And I'm not talking about taking, a heatless Mizzy wheel and grinding it down, but get that tooth out of occlusion. You can even use some shim stock paper. Do you see? The first time I've used the term shim stock paper. But also that'll help them make it more comfortable. Obviously, they can take some NSAIDs, but I think the idea of giving a block is a good idea. Yeah. And I'm assuming that when you do this, Ali, you're using a long-acting anesthetic.
Yeah, of course. Everybody has a busy day from time to time. Even myself, if I see a patient for an emergency, I may not be able to get to them until the end of the day. But the patient who's in acute pain needs to be kept comfortable. And that's when a long-acting local anesthetic in the form, if it's in the mandibular jaw, in the form of a block, or if it's in the maxilla in the form of either a PSA block or a buccal infiltration alone, of a long-acting anesthetic, such as the bupivacaine in the form of Marcaine, would be very helpful, because it'll keep the patient comfortable and out of pain until you can get to them.
There's only one tip that I'm going to offer here, and consider this a real-world endo tip when you're using Marcaine. What's the tip?
So because Marcaine has a certain level of myotoxicity, it's pretty painful injection.
So the pH
exactly. So as well as the fact that it contains some epinephrine and the pH and so on. So it's always a good idea to provide a painless pre-anesthesia, such as the mepivacaine plain, prior to the injection of the Marcaine. So it just makes it one of those things where a patient who's already in a lot of pain doesn't need that extra higher level of pain from the shot itself. They're nervous and anxious.
I've never given a shot of Marcaine straight up on a patient. I mean, you're going to pick that patient off the ceiling.
Yeah.
So having a little bit of xylocaine, mepivacaine, that's good. In the max triage, will you use an articaine or a septicaine infiltration? You get a little bit longer acting time than your typical xylocaine.
Yeah, it is. Marcaine's ability to stick to the receptors a little bit longer is just a function of its own chemistry. Comparatively speaking, with xylocaine, mepivacaine, lidocaine, mepivacaine, or any of the other, or articaine, it just does have a longer duration of pulpal anesthesia.
Here's another question, because I can see you. You've got your hand raised, and I know this is your question. And the question always is easy to predict. Antibiotics. Do you need to give any antibiotics in this case where this patient feels like the head's blowing off?
So the key point here is that we're talking about a case of irreversible pulpitis, and the administration of antibiotic for cases of irreversible pulpitis is completely contraindicated, because what actually ends up happening, irreversible pulpitis, Annie, as you know, has a certain kind of a lifespan before it progresses to become necrosis.
Right.
So that acute pain that is a result of the compression of the nerve inside the pulp chamber that's encased is just a temporary time. So it takes a certain amount of time, and then the pulp dies and the pain goes away. Antibiotics actually can prolong that time in the case of irreversible pulpitis. So patient actually stays in pain longer. So irreversible pulpitis should never be treated with antibiotics. If the patient comes in with a huge swelling and has
that's different.
Obviously that's a different story, and has signs of systemic toxicity, then antibiotics would be helpful.
Do you like to put a little bit of NSAIDs on board? In addition to giving this person a Marcaine block, would you think about maybe 400, 800 milligrams of ibuprofen?
Yeah, of course, as long as the patient's medical history is okay for taking non-steroidal anti-inflammatories, 600 milligrams or 800 milligrams of ibuprofen is helpful. A combination of 400 to 600 milligrams of ibuprofen with 500 milligrams of acetaminophen.
That's a great pain relief.
Exactly.
Elliot Hirschtown at the University of Pennsylvania has done a lot of studies with that. It's amazing. It's equal to like narcotics.
It is equal to narcotics without the side effects.
Absolutely.
And the reason for that is because you're getting the pain at two different levels. Acetaminophen works at the level of the brain, and the NSAIDs work at the level of the inflammation around the tooth peripherally. So you get it from both levels, and that's what it works. But I think the key point, Annie, that we were trying to set forth here and move forward is the idea that you should never do a tooth you're not comfortable in doing. You shouldn't be forced by a patient who's in pain.
Absolutely.
Because why? Because if anything goes wrong, what happens? You still own the tooth.
And you know what takes the most confidence in endodontics is to do nothing.
Exactly.
That takes incredible confidence. So if you can't reproduce the chief complaint in terms of making a diagnosis, or if you just don't feel comfortable opening up the tooth, don't feel funny. That takes incredible confidence to say, I'm going to send this out. But now we've given you, I think, some good real-world endo tips, practical tips, how to make that patient comfortable and make it eventually a successful result.
Absolutely. Have a good relationship with your endodontist. Make sure that you only do cases that you're comfortable with. If not, refer out or wait out until you know what the tooth is. That's a whole diagnostic issue. And keep them comfortable until the time they can be seen. And that's all helpful.
Absolutely. When you do endodontics that way, you know what I think? Too easy.
Too easy. All right. With that, I'm Ali Nasseh.
And I'm Ann Koch.
And we hope you found this information helpful.